Thank you, and thank you to everyone for joining us on today's COVID-19 daily media call for May 28th. Governor Walz is not on today's call. We'll start with a situation report from Commissioner Jan Malcolm. Following Commissioner Malcolm, we'll get an update from Infectious Disease Division Director Chris Eiersman. And then after those updates, we'll open it up for questions from reporters on the line. With that, I will now turn it over to Commissioner Malcolm.
Thank you, Mike. Good afternoon, everyone. Before I go into the the data brief, I just would like to note that the context in which we're talking today, the tragic events in our community that we talked about yesterday at the briefing, the pain and the anguish, the sadness, the anger, so many strong emotions, and such a powerful reminder of the broader forces at work that threaten health in our communities for all of us, but for some of us more than others. So I just wanted to acknowledge that for once, COVID is probably not on the top of people's mind today, and rightly so, and to acknowledge that, of course, people are moved to want to speak and to want to gather in solidarity and in protest, and we certainly honor and respect that right. As we know, large gatherings do pose a risk in any epidemic, but certainly where we stand today with the state of COVID-19 spread in our communities, knowing that we have community spread, we just want to, again, encourage folks who may be gathering to please just be mindful of the risk, and that risk can be reduced, certainly not eliminated, but reduced by social distancing and wearing masks, and we fully recognize how difficult that would be in a situation like this. But again, just quite a heavy day on many levels for so many. With that, into the daily data brief for COVID. Globally, as of this morning, there were more than 5.7 million cases and 356,000 deaths around the world. In the United States, as of this morning, we were very near 1.7 million cases and had passed that very sad marker of 100,400 deaths. Here in Minnesota, we added another 493 confirmed cases yesterday, bringing our total to 22,947. I will note that daily increase of 493 continues another string of 5 days in a row of reducing case counts, which we had seen last week as well until we saw a rather dramatic uptick. So it's just notable to see how the pattern is going up and down, but that we do have periods of decline in our numbers, which is a good sign. Unfortunately, we also had 35 reports of deaths from COVID-19 yesterday, 35 more of our family members, friends, and neighbors, bringing our total of deaths to 967 in Minnesota. This daily total of 35 is the highest daily total of deaths for a single day so far in this epidemic. Of those deaths, 16 of them were in Hennepin County, 7 in Ramsey, 5 in Dakota, 4 in Anoka, 1 each in Benton, Itasca, and St. Louis. This total includes 2 persons above the age of 100, 3 in their 90s, 15 in their 80s, 6 in their 70s, 4 in their 60s, 3 in their 50s, and 1 person in their early 40s and 1 in their early 30s. And at this point in time, there are no known underlying health conditions reported for the 2 individuals in their 30s and 40s. There are currently 606 patients in the hospital, 242 of them in the ICU, with a net change of an additional 8 in hospital total, but a reduction of 18 in ICU beds. I'd like to just mention that the Today's case total of 493 was in the context of the highest daily volume of tests that we have been able to yet report, 8,676. Much of the increase today is from what we believe is the final processing of the mobile testing at the armories over the holiday weekend. And so that we believe that all of those, we believe most, if not all of those tests have now been accounted for in the laboratory reports. And we expect to have some information to share with you about what we were able to learn from that community testing next week. With that, I think I will turn it over to Chris Erzman, who's on the call with us today, for some comment, and then we'll be open for your questions. Chris.
I'm just going to turn it back to Mike and be happy to take questions. Thank you.
Thanks, Chris. We will open it up for questions now. As always, we ask that reporters limit their questions to one primary question and one follow-up so we can get to as many as possible, and also try to limit the questions for each outlet so we can get to as many different outlets with their questions as possible. With that, operator, we're ready to take questions.
Thank you. Ladies and gentlemen, as a reminder, if you would like to ask a question, please press star, then the number 1 on your telephone keypad. Your first question comes from the line of Emily Havoc with Carrier 11. You may now ask your question.
Hey, Jan and Chris. Thank you for taking my question. Just following up on the questions about COVID cases among children in Minnesota, and then, a high percentage of those being children of color. Do you have any more info you can share today about any outbreaks that you might be seeing among kids and where those cases are coming from and what the numbers are like today?
Thanks. Chris, can you address that?
Yep, we are seeing cases in children, and if we look at cases in the under 20 age group, it represents about 25% of our cases. We've had 397 from birth to age 5 and 1,536 from 6 through 19. So we are seeing cases in children, but it is a much smaller proportion of our overall cases. We're tending to see obviously many more in older adults because that's where we focused our testing. We have seen some cases or clustering of cases in children, sometimes related to child care, but that is not, I guess, unexpected just because of the gathering together. We know that child care are following our guidance in terms of limited group size and things like that. But even with that, we have seen some cases. But as I indicated, the proportion of cases that we're seeing in children is very small relative to the total number of cases.
Thank you, Chris. And can you share any information, about where those outbreaks are? But if not, can you tell us if parents and families have been informed if there are cases at their child care?
Yes, you're probably aware of the fact that, we talk about situations with manufacturing or with long-term care. And so we have teams at the department that are working in each of these areas. And so we have a team that's working with schools and child care. And so that team, in conjunction with local public health, in wherever we're seeing a situation, is working with the facility. And so, yes, they work to do interviews to look at how transmission may have occurred, and as part of that process, parents are made aware of the situation.
Your next question comes from the line of Jeremy Olson from Star Tribune. You may now ask your question.
Hi, Commissioner. I just wanted to get you to put where we're at with this pandemic in context with the nation. You talk so often about our state numbers, but I'm wondering how often you look at our position compared to other states. When it comes to testing, cases, and deaths, how are we doing? Are we doing better, worse? What's your thought on that?
Well, thanks. It's a great question, and we do track that. We look frequently at how the shape of our curve compares with others, and generally, I think what you see is that the shape of the curve is. We had a longer period of quite slow growth. I think that was a result, of strong early efforts from Chris's team to follow up well and quickly with cases as they were identified to get people isolated and quarantined if they had been exposed, and the fairly rapid action that the governor took to use some of those community mitigation strategies of social distancing and limiting group gatherings and so forth. But we do see, even though we had a longer slow growth period than many, the slope of our curve as community spread began to take hold looks quite similar to other communities, potentially of unknown duration. As we've said many a time, where we believe we're still climbing the curve. I've mentioned a couple times a couple of periods now that we've had of some stability for days at a time. So we don't know if this is sort of a mini plateau. We're actually in conversation right now about trying to assess various data points, but we think generally we're doing quite comparably with other communities. Chris, you want to add anything?
No, I think that's good.
If I may, as a follow-up, then what about testing? I mean, we made a pretty big deal about the U and Mayo partnership getting us up to 20,000. And I don't know if you have any thoughts on whether we're going to get to 20,000. I thought it was supposed to be at the end of May. I don't know if we're getting there. But also, it seems like other states are doing a pretty good job on testing, too, and may even be testing at a higher rate than us. How are we doing on that testing rates, I guess?
Yeah, great question. We certainly do track that, and we have been, I think we are currently number 29 among the states in terms of testing on a per-population basis. But the goal that the governor has set, you're right. I mean, the Mayo and U and statewide partnership has a goal of creating the capacity for 20,000 tests per day in June. I think the governor had said he wanted to see us hitting 10,000 tests a day by the end of May, so we're very close to that. But the goal is, has been 20,000 in June. We now have expressed that in a different way, more comparable perhaps to being able to measure against other states. Our goal now is 50 tests per 10,000 people per week, and on that metric would get us into the top tier of testing on a population basis, and that we're heading there. We're over 30 tests per 10,000 now, so we've made really good progress in the last couple of weeks.
Your next question comes from the line of Bill Werner with Minnesota News. You may now ask your question.
Hi, Commissioner, and hi, Chris. Also, can you give us an idea? And I see that the ICU pressure eased a little bit today, but I know it goes up and down. I think 3 of the 8 regions of the state were in yellow, if I'm not mistaken, as of the information yesterday. Has that changed significantly, or perhaps not? But how close are we to the point where we're going to have to perhaps divert some of the more serious COVID cases out to the hospitals in other sections of the state, away from the metro or away from the yellow areas, and also the alternate care sites? I know they don't do those, if I'm understanding, are not designed to handle the most acute COVID cases, but who would go there, and what kind of timeline are we looking at possibly in terms of activating both of those options?
Those are great questions. I think what we'll do is get Dr. Hick to join us for a call early next week to give you a little better quantitative answer of what kind of criteria would trigger either the opening of the community care sites or the transferring of patients around. That our system is designed to do exactly that if needed, to know where there is availability and to assist facilities in finding places for patients in need of various levels of care. I mentioned last week, I think, that a couple of our level 1 trauma centers had activated some of their surge beds. I don't know if that is still the case, but they, as you said, we have seen some fluctuation up and down in the ICU numbers. I think I mentioned some of that volume was due to a significant number of procedures that had been deferred earlier. And I think that's a very good thing, that the procedures that are being done are complex neurological, cardiovascular, and cancer surgeries. And so when we hear from systems that they are catching up on the backlog of those kinds of cases, that's a very good thing.
And Jan, can I just add that I just want to express that this system that we're talking about is one that does get utilized in that during a severe flu season, we can see, 95+% of our ICU beds being used. And so the system is tested at those times. And so it's not a system that isn't used except for COVID. It's a system that has been tested in the past, and we do see these increases in ICU capacity use even during a severe flu season.
Just a quick follow-up, if I may. Just in terms of timeline, do you think we're, a week away from perhaps having to divert some cases out to other hospitals? And when we're at that point, where will they go? And will those hospitals get extra support from the state if they're rural hospitals in particular to address those cases?
Again, great questions, and I'm just going to get Dr. Hick to join us to give you a little bit more in-depth insight into those questions. I don't think that certainly I don't have a forecast of when in time that might be. Dr. Hick may or may not, but he would be better able to address what would be the triggering events, so to speak, for that to happen. Certainly, as we've mentioned, the rate of hospitalizations has been on a pretty steady increase, with some bouncing up and down from day to day on ICU levels. But in general, the rate of hospitalizations has been continuing to grow. And so it's a really good question. And I'll just beg your indulgence to get Dr. Hick here to talk about that in a couple days.
Your next question comes from the line of Tom Hauser with KSTP-BV. You may now ask your question.
Hello, Commissioner and Director Erzman. It was 3 weeks ago today when you announced the battle plan to address the number of COVID-19 deaths in nursing homes. At the time, 407 of 508 deaths were in long-term care, or about 80%. In those last 3 weeks, 380 more people have died out of 459, for 83% in that 3-week period. It seems the problem has actually gotten worse, and Minnesota's number of nursing home deaths now exceeds total deaths in the state of Wisconsin. Is there a goal for when that battle plan is supposed to start showing results? And are you disappointed with what has happened in the past 3 weeks?
Thanks, Tom. I think the focus on deaths is certainly understandable and is a very, very critical metric. But I think the point of the battle plan is not just is not solely measured around have we reduced the percentage of deaths. And I would need to dig into the last thing you cited there about our nursing home deaths being more than all of Wisconsin. I believe probably what you're looking at is the total of all congregate care systems and not just nursing homes. If you look at deaths from skilled nursing facilities only, which is the only thing the feds require to be reported, and which we believe most states are reporting, that comes down to 54% of our reported deaths. But we can get more into that data question later. But the other things that we're really looking at are the ability to prevent spread in these congregate care settings. How many times can we help facilities keep infection rates and keep cases in the very low range. It is still the case that over 50% of the, first of all, a fairly low percentage of facilities have any cases at all. Over half of those who have any cases have only one or two, and over half of those no longer have any. And so that too is a measure of success. You know, how well are facilities able to manage cases, and how good a job are we doing supporting them in doing that. And then of the cases, because there definitely are facilities with larger number of cases, you know, how successfully are they, and are we helping them to manage those and reduce those larger outbreaks? And among those with larger numbers of cases, fully a third of them have had no new cases in a week. So I would suggest that there are measures of success in the plan, and in terms of the number of folks from congregate care facilities who are dying of COVID, you know, certainly those are large and concerning numbers. As a percentage of our total, again, I just would say, and we ourselves are trying to dig into this to make sure that our theory about just the lack of comparability of numbers, that's our theory. I want to see the data to see if it's the case. But we know that a lot of states, if someone from a long-term care facility dies in a hospital, that is not counted as a long-term care death. We do count it as a long-term care death if they were a resident of a facility, even if they died in hospital. So sorry to go on and on there, but I think it's a really fair question. Of course, people are very focused on it. I just simply wanted to say there are layers to be explored in what are the numbers and what are the measures of success. But I did want to point you to some of those success measures in control of outbreaks.
Thank you for that. Just a quick comment on the data, and then I have a follow-up. 787 long-term deaths in Minnesota. Wisconsin has a total of 545 COVID-19 deaths across the whole spectrum. So those are just the data points right now. Am I still on? I heard some weird.
Yes, you are.
So,
yes, you are.
Okay, a quick follow-up. Is the Department of Health going to require bar owners to keep logs of customers who come in for contact tracing purposes? I understand that's happening in hair salons. Is it going to be required that they keep logs in bars and restaurants? And if it is true, is that also going to be extended to churches and other businesses for contact tracing purposes?
Thanks for the question. That is an important thing to clarify. We did say in the guidance that it would be a preferred practice for restaurants and bars to be taking reservations, but really that was more about controlling size of occupancy and avoiding people, you know, standing in lines trying to get in. To be clear, that they are not required to report those data to the state health department. It is and has been in the past a valuable source of information if there is an outbreak, to be able to go back and find out who was there. That's a really helpful tool. But restaurants and bars are not required to report that to the health department on any routine basis, and the reporting of it is voluntary.
And Jan, I'll just add that, I mean, yes, we're doing contact tracing and follow-up for COVID, but remember that we follow up on multiple different infectious diseases all the time, and so we're used to dealing, if there's a foodborne outbreak or that type of thing, we do have ways that we can work with restaurants and other facilities to identify patrons. So just reminding people that this is something that we deal with regularly when we're not in COVID mode.
Your next question comes from the line of Catherine Richard with Minnesota Public Radio. You may now ask your question.
Yeah, Commissioner Catherine Richard here with NPR. Could you just go back to kind of what you said at the beginning of the conference call about these crowds that are developing in downtown Minneapolis and now St. Paul? Are you anticipating in a couple weeks we're going to see some serious outbreaks here? And how would the test handle that, or the state handle that situation, given the potential volume of positive tests that could come out of these situations?
Well, I mean, it is certainly going to be a factor in what happens in our outbreak and in our case counts. I'm understanding that the forecast is for very large protests this weekend, with a lot of people coming in from across the state and from around the country and gathering in large groups, and that is almost sure to have an impact on furthering spread. It's part of why we just encourage people to be mindful and to do what they can to mitigate the risk of gathering in such circumstances, while completely understanding their legitimate right and need to speak. But yes, I don't have any quantification of it, but we would expect that the gatherings of the size that are expected under the conditions that we are experiencing would very predictably accelerate the spread.
But we have been ramping up our ability to do case investigations and contact tracing gradually over time, and so we're in a much better place to respond than we may have been 4 weeks ago.
Chris, could you tell us more about that? How many contact tracers do you have as of today?
I believe we're over 600 case investigator contact tracers. That's within the department as well as partners in local public health, and we're continuing to add to that capacity.
Your next question comes from the line of Chris Megan from Pioneer Press. You may now ask your question.
Hi. Was wondering, looking at the death records of those who've died from COVID-19, has anyone done any type of analysis of the underlying conditions and which ones may be most present in those that have died, and which ones put people at greatest risk of death? When it comes to just underlying health conditions, I see there's sort of a wide range of conditions that are listed in the death records.
Yes, there are a number of conditions. I'll let Chris speak to what the data show so far.
Chris, when we look at the cases who have died, we have, for the data, I can tell you that 97.6% we have identified some level of pre-existing condition. This is in our broad overview of interviewing cases, and just to be more granular, that 653 who've had an underlying health condition, 16 who have not, and then 298 that we're still working to get data on. We are doing a deeper dive, and so all of our deaths are being evaluated, but not in a real-time basis. So in other words, we don't have that data updated on a daily basis like the data that I just provided for you. But when we look at the underlying health conditions, I mean, we're looking at heart disease, diabetes, lung disease, multiple factors like that. And I can get you that information via email.
Okay.
You need that.
Yeah, that would be helpful. I was wondering, is there any in particular types of conditions that stand out that seem to be among the most of the cases, or is that something you could provide?
Yeah, I'll check to see where we're at with the case fatality review. But yes, I will look at that. And I was just trying to pull up all of the information that we collect on underlying conditions, but I will get that for you.
Thank you so much.
Once again, if you would like to ask a question, simply press star, then the number 1 on your telephone keypad. Again, to ask a question, please press star, then the number 1 on your telephone keypad. Your next question comes from the line of Chris Rogers with Winona. You may now ask your question.
Thanks, Commissioner. Thanks, Director. Is the MDH checking whether long-term care facilities have trained their staff on infection control, whether they're doing the screening they need to, and whether they're generally prepared to contain an outbreak? And if so, how are you doing that?
Thanks for the question. There are nurse case managers assigned to each facility that has any cases at all, and there are teams of folks from Chris's department who consult on infection control. So the nurse case managers are kind of keeping an eye on implementation of the recommendations, and Chris's team is really doing the education. And I apologize if you can hear the feedback, the echo that I'm hearing. Hopefully not. Hopefully it's just me, but apologize if you're hearing it. Thank you. That fixed it, whatever that was.
Sorry about that.
Yeah, so go ahead, Chris.
Well, Commissioner, I was just going to add that a couple of additional things. One is that we started working with facilities about this even before we had any cases identified in a long-term care setting. So we had started working with facilities, talking about things they needed to prepare for, checklists, things they should be considering. So we were doing that pre-cases in facilities, but I also want to talk about the fact that our team had been working with facilities for the last 3 years. We've reached out to and done on-site visits with about 50% of all the facilities related to infection control and prevention and best practices. And that was our team. We are the team under in my area is not in a regulatory role. So that was really outreach to say, how can we help you do the best that you can related to infection control and prevention. So those things were all happening prior to COVID. And then once, as the commissioner said, a nurse case manager is assigned, and every single facility that has a case identified receives a virtual, review of their infection control and prevention practices. But in addition to that, our health regulation division has also been going out to facilities and doing some on-site trainings as well. So there's been a lot of attention to this, not only as a part of our response to COVID, but even prior to that. But the challenge is that facilities are often strapped because they don't have the necessary capacity to have staff that can focus on some of these things, as well as there's oftentimes a high turnover in these facilities. And all of those things certainly add to the challenges that a facility faces as they are trying to implement best practices related to infection control. But just want to add to what the commissioner said, that this has been on our radar even before COVID, and we had reached out to 196 facilities with on-site visits prior to COVID.
Thank you. Chris, has the MDH been able to confirm whether all long-term care facilities in Minnesota have the plans and training and screening in place they need?
That is a requirement. Some of the planning is required through our health regulation division, and so what we're doing is we're both, as the commissioner alluded to, and as we talked about the 5-point plan. Part of our goal is to move upstream and reach out to facilities that we anticipate may have more challenges. But part of the expectation for facilities is that they do have a plan in place. And our goal with our case managers has been to be an at-the-moment review. So in other words, it's great to have a plan, but if something happens tomorrow, have you reviewed that plan? Have you thought about it? That was what our goal was in starting to talk about this early when COVID was just appearing in Minnesota before there were cases. And then even as we identify a case in a facility, we start to work with them again because they're going to be that much more attentive to what needs to happen. And so we're trying to work with them at multiple different levels and multiple different times.
Your next question comes from the line of Chris Snowback with Star Tribune. You may now ask your question.
Just a follow-up on the volume of testing. Several weeks ago, you all said that the state had more testing capacity than takers for tests. I wondered if that has continued to be the case, and if, in fact, the gap has gotten wider.
Oh, actually, thanks. That was a part of the motivation for doing the community testing last weekend, was that we knew that we still had unused capacity, underutilized capacity, and so in a pretty short order, the decision was made to do some testing in community sites. We have also been using a lot of testing in long-term care facilities to get to our goal of having all facilities with any cases at all having access to testing for all staff and all residents. So that's been a priority, trying to use more of that capacity for that priority population. But that is, we have to work with facilities to schedule that. So, and we are scheduled out into the future with facilities wanting that testing. But because we still had underutilized capacity, that was exactly why we did some of those community sites last weekend. And we can also get that data back to you and either have a future conversation about it in this call, or get it to you in follow-up. What the current how that number has changed over time. I don't believe it's gotten any worse, but I don't think it's been completely taken up yet either.
I guess just a real quick follow-up. At the time, the governor had said the state had capacity for 10,000 tests a day. So I would assume that has only grown. I don't know if that's true, but I think the daily completed test totals are not anywhere near the using 10,000, which makes me think. I mean, do you know what the capacity is right now?
Not off the top of my head, I don't. You're right. It was over 10,000 last time we talked about it. And again, today's testing number was the highest total that we've had in a single day so far at 8,676, I think I said. So that's getting close to that capacity, but I'm quite sure we are over 10,000 in capacity now. And again, the goal has been to get to the capacity for 20,000 tests a day.
Thanks.
Once again, if you would like to ask a question, please press star, then the number 1 on your telephone keypad. Again, to ask a question, please press star, then the number 1 on your telephone keypad. Presenters, we don't have any further question on queue. You may continue.
Well, great. I will just step in at this point and thank everybody, including our speakers and those on the call today. If you do have follow-up questions or questions you weren't able to ask on the line, feel free to reach out to the MDH Communications Office. We will talk again soon.
Find more local news stories at ccxmedia.org and follow us on social media.